Good morning, everyone. Thank you, Rochelle, and thank you, Steward Gaffney, the other Steward Gaffney, different, for organizing this town hall. Today, we have a special town hall. It's a combined effort of the Division of Prevention Science, several units, tabs and caps, and it's my great pleasure today to introduce our dear colleague, Professor Wayne Steward, who will be talking to us about affecting change in healthcare systems, transforming policy and practice to improve HIV outcomes. Before we go ahead, let me tell you a little bit about our dear colleague. Dr. Wayne Steward is a professor of medicine in the Division of Prevention Science, and he co-directs the CAPS Implementation Science and Health Systems Core. His research broadly focuses on enhancing the delivery and quality of HIV care through organizational and policy level changes. His work encompasses United States-based research that seeks to improve coordination and efficiency of care to improve HIV outcomes and reduce disparities, as well as international research that looks at organizational change and uptake of navigation style interventions to improve HIV retention and care among underserved and stigmatized populations. Thank you, everyone, for joining us. Professor Steward, the mic is yours.
Thank you, Jesus. It is good to be with all of you this morning. So I'm gonna run you through a variety of different things here, talking about health systems and about making changes in health systems. Let's see if I can get this thing. Here we go. I think the first thing to do just before we get started is to set the stage by what we mean by a system, because it helps to have that common grounding. So I did go and look it up in the dictionary, and the Google definition of it from Oxford Language Dictionary is there at the top part of the screen, which is it's a set of things working together as parts of a mechanism or an interconnecting network. The latter, the interconnecting network, really being the thing that's going to be more critical when we're talking about a health system. And so, if you take that definition and then you specify it further down to thinking about a healthcare system, you're going to get into this looking at a set of entities that are working together in some sort of way for the provision of medical care and supportive services. And I do just want to note that if you look up healthcare as a definition, the definition you would get officially is really focused on core medical services, so things like medications and hospitalizations and surgeries and things like that. And you will note that I've expanded it out here a little bit because, at least in the context of HIV, and I think in the context of a lot of conditions that we look at, you have to go beyond just core medical services and also think about your public health infrastructure, your kind of care that gets delivered in community agencies and sites and similar. And the reasons for that will be evident here in the next slides. So why the focus on systems? Let me just address that issue. This is a topic that I think is it's a little foreign, I think is fair to say to some people. They're certainly familiar with the system, but how to actually go about studying a healthcare system is not always very easy. So why would you want to look at it and sort of take that burden on? Well, one of the reasons is that, and perhaps one of the most important, is we simply have an implementation gap. This is a point that has been well noted in the field of HIV. I think it's true in a lot of other health conditions as well. In the context of HIV, we actually do currently have tools that could prevent and treat it and do so, maybe not with 100% effectiveness, but very well close to it. That's not to say that there isn't room for further improvements or things like vaccines, but the point being that even with the tools we have existing today, we could actually, if you wave a magic wand, largely take care of HIV. But the challenge that, of course, we face, and that many of you would be familiar with, is that we have a lot of trouble getting the right tool to be used at the right time by the right person. And so what ends up happening is the promise of a whole lot of interventions doesn't get fully achieved because of these implementation challenges. And then the gaps, when you look at them, of course, are not evenly distributed. So we have a host of HIV-related health disparities, much as we have disparities for many other health conditions that cut across race and gender and sexual orientation, age, different countries, all of this, of course, being very important in the context of HIV, since HIV is basically a disease of people who are dispossessed in some way, of the poor, of people of color, of gay people, of people in poorer countries or lower income countries. And there's, in addition to those disparities, those disparities themselves, I should say, are really driven by a whole lot of social determinants of health as well as stigma. And so those social determinants of health are not always things. In some cases, they're things you might treat in a traditional medical care setting, but not always, right? And so you get things like education access and quality, economic stability, your kind of social and community context in your neighborhood and built environment. The other reasons to consider looking at systems have to do with the fact that people with HIV just now live longer thanks to the improved treatments that we have. And as a result, they face comorbid conditions. We have an aging, here in this country especially, we have an aging set of people with HIV, and they're increasingly facing things that are not HIV related, but that you have to treat that in the context, right? Something like heart disease and things like that have to be treated in the context of a person also having HIV. And so that complicates where they're going to get their care. And then healthcare delivery is under strain. So, there's a variety of evidence that exists out there, and it existed before the COVID pandemic, right? That pointed to, we have a larger exodus from HIV specialty care than we have people rolling into it. So we have a specific challenge with the availability, or we will have as we continue along with the availability of HIV specialty care. We have, more general to that, a variety of studies that point to there being a potential shortage of primary care providers, particularly if you're talking about them being physicians. And that, that too creates strain on the healthcare system as you have a growing population that needs primary care. We have overall trouble retaining professionals in the field, and this is a problem that has only been made worse since the COVID pandemic due to the strains of actually having to deliver care during the worst of the pandemic. And just the other day, I got stuck in a car coming back from SFO and had a long time listening to NPR. And I would say there was no fewer than 3 stories in the course of an hour and a half. I was in the car about the shortage of providers that we are experiencing in different parts of the healthcare system here in the United States. In some cases, looking at up to 25% of positions being vacant. And just the fact that COVID means that we have a more a sicker population. Basically, there's a lot more acuity in terms of the care that's being sought as a result of things not being taken care of during the pandemic, because everything got halted in order to deal with COVID itself. So now, with that as a backdrop to why you'd look at systems, it's just worth taking a moment to think about what we're talking about when we think about a system. And so of no surprise, right, a system, and this is what makes them complex, has a whole lot of different components, and they sort of build from a very kind of outermost circle going down in, but you're going to have your policies and procedures that shape your system, and they can be imposed externally or come internally. You have a whole host of infrastructure, from your facilities to your IT systems to the other kinds of resources and supplies you need. You have stakeholders, they of course actually being clustered within units themselves. So you have leadership, you have providers, you have the patients and clients, you're going to have your informatics or tech people. You're going to have your legal and regulatory experts. Your patients, of course, are going to be nested within providers, your providers working under leadership. But each actor within a system has their own knowledge and their motivations and they can come with a unique position within the system and a unique perspective. So, there isn't one system that we actually are looking at. What we're actually looking at is a whole bunch of separate moving parts. And then, of course, you've got your services and interventions to be delivered. And these all layer up into a set of challenges or things that you have to consider, things related to the intervention and how an intervention needs to look to work within a system. You have issues with the health delivery system itself in terms of characteristics of the providers and clients and the resources available that make the rolling out of any sort of change possible. And then all of that is embedded in this larger context of policies and other kind of contextual elements that may or may not support making a particular change. So when you end up looking at this, what I will say is, when you go to study a system, you can potentially pull from behavior change, implementation science, organizational change, quality improvement, policy, and even informatics and data systems literatures. And when you look across them, what you basically get is a very large number of things that you could potentially be considering and trying to understand how to affect change in the system. And it sort of sums up to being an ecological focus. Now, ecological kinds of models are they're comprehensive. They get kudos for that. They don't ignore anything, but they do suffer a little bit from lack of parsimony because everything basically relates to everything in the context of that kind of model. And for the person sitting down trying to figure out, well, what do I need to do to affect change in the system? It's overwhelming. So it's really the question becomes, where do you want to look? Where do you begin? What are the things you need to focus on? And that's what I'm gonna run through a set of studies here, trying to pull out those points and what those lessons are. And I'm gonna do this in 3 blocks. I'm gonna start by talking about some research in South Africa, move to talking about some research on practice transformation in the US, and then I'm gonna specifically move to some more recent research during the COVID era. And I've segregated out the stuff in the COVID era to its own piece because COVID has this way of swamping everything. And so you're trying to say, well, where do you need to put your efforts to understand systems change? Looking at it only in the COVID era gets a little muddied. So I'm going to begin by talking about this work in South Africa, and particularly this study called iCare. And I'm starting here because it was a study that looked at actually rolling out an intervention in a very traditional kind of model where you had an intervention, you tested it, and you looked to see how it worked within the system itself. And there were some lessons learned from that then lift off for further consideration about making change in the health system. So just as backdrop for that particular study, this was done in the context of HIV care in South Africa, which does have the largest ART program in the world, but where there's a substantial number of people who don't get all the way to viral suppression. It's clear that simply expanding over time, South Africa has repeatedly expanded its ART program to the point that it's now considered to be universally available to anyone with HIV in the country. And it's still not completely solved the problem. And so there need to be complementary strategies for engaging patients and keeping them in care. And so in the context of this, my colleagues and I developed and tested 2 intervention strategies. And this work was done in the Northwest province of South Africa. So the first of those strategies was one that you could think of as more of a tech strategy and a very simple, low-tech strategy, actually, of just using an automated SMS system. And it was designed to give patients appointment reminders or reminders that they were due to come back to the clinic for their medications, as well as a very simple check-in message system that basically asked if a person was doing okay and where they could enter a number that indicated okay or not okay. And if not okay, then someone from the clinic could call to check on them, as well as some occasional health promotion or behavioral messages. And you could think of them as kind of pep messages, right, around like health prevention, engagement in care, adhering to your medications, and just overall healthy living. The second and more involved intervention, though, was one that took some of the elements of that reminder system and then paired it with a navigation component. And so what we did is we trained peers to provide support and help patients navigate HIV care and prevention. And the idea was that it would provide a much more personalized source of support than something like the existing standards of care would do, or the SMS only intervention could do. And so there was a minimum of having to meet with these peers once a month. There was regular phone and SMS contact, with the navigator actually personalizing the communications to the clients, and then accompanying the patients to clinic appointments when desired. We started this by first piloting both of these interventions, and particularly with the peer navigation intervention, conducting some focused interviews to understand how that intervention was working and what it did and didn't do for the patients and for the navigators and for the providers that they were working around. And what we found was that the navigation was basically acceptable to all of the stakeholders, from the patients themselves who got a lot out of it, to the navigators who actually personally benefited from delivering the navigation, as well as to finding it rewarding to be offering their help to other patients. And then also importantly to the providers, who were quite pleased with the fact that more engaged patients who were kind of better situated is a better situation for the provider. So you saw wide acceptability for the intervention. And what was also notable in the findings was that a lot of this work really was driven by the ability of the navigation program to address the effects of stigma. So patients who are relatively newly diagnosed, many of them were experiencing quite severe isolation and just sense of being overwhelmed and depressed about the fact that they had HIV. And so meeting with a peer gave them, this was predicated on this idea of social modeling. It gave them an image for what it could look like to be a person thriving with HIV, or at least functioning with HIV and functioning well and staying engaged with the system. And so it really acted as the mechanism of action. It drove the rapport between the peer and the clients, and it drove a lot of the reactions that the clients had and their willingness to learn and take up information from their navigator. That piloting of the interventions was then followed by a randomized control trial, where we took 18 different clinics and randomized them to 3 study arms, right? One for the SMS only intervention, one for the SMS plus navigation, and one for standard of care. And within those clinics, 752 participants were enrolled, all of whom had to be diagnosed within the prior year. For the trial, we followed up with clients for 1 year, extracting data on the receipt of medical care from their clinical records. So we relied on they had to actually show up, and it had to get noted in the system for them to get credited as having had an appointment at the clinic. And we use the following definitions for retention in care. And it should be noted, at the point this was conducted, this was before South Africa fully implemented its universal or its universal access to ART. And so there were patients who potentially were not yet eligible for ART medications. The vast majority of the patients, though, were. And in that case, the rule we followed was that you could get medications in up to a 90-day supply. And so we stated that you could not go more than 94 days between clinic visits. And the reason for that was we tied it to South African standards for adherence, which said you had to be 95% adherent. And if you go more than 94 days, you're going to fall below that standard with the 90-day supply. And then for pre-ART patients, we tied it to the standards for how frequently you were supposed to come in for monitoring to see if your CD4 levels had dropped to levels that would make you eligible. And so you're supposed to go twice a year. And so we tracked for that. And then we used GE to intention to treat analyses to account for clustering. What you ended up seeing is denoted here. Let me just say, first of all, the first thing that's probably the most notable thing is just the simple effect of being on ART, that there's a whopping difference between retention if you're an ART patient versus not an ART patient. And so it suggests good things for going to universal ART, but most importantly, there was a significant effect of this SMS plus PN intervention. It substantively improved retention over a 1-year period. People ended up coming to the clinic on average about 2 more appointments over the course of a year than if they did not get that intervention, whereas the SMS only intervention did not have that effect. So let's just stop and take a moment and say, well, what do we get from this? So what the iCare study did do in terms of rolling out change in the system was it successfully introduced a peer role to provide personal support. And the navigation was able to focus on this overcoming feelings of stigma and addressing barriers to care that might not otherwise have been well addressed in the healthcare system. Personalized attention was welcomed by patients, and the support could be delivered flexibly, and it was widely popular with the clinic providers as well as with the patients and the navigators. But what it did not do was it didn't require that the clinics themselves have to supervise the navigators of the SMS system. We had created it as part of the intervention, and we had largely managed it. And so the system wasn't the one totally running it. It's more like the system let us in to run it rather than the system fully being the one that was running it itself. There was also an issue of external policy decisions taking place within the district that moved funding away from this kind of intervention at around the time that the study was coming to an end. And so what ended up happening was, although we had this efficacious intervention and it worked and it was clear it was popular with everybody and it worked within the system, there was a real struggle translating it over to be owned by the system. So with that in mind, we then did some follow-up work, shifting where we were doing the work over to KwaZulu-Natal to look at understanding uptake of successful interventions. And in this case, it was a small study funded by our CFAR, and we looked at we talked to providers about what it would take to actually, like, what is it that they see as driving uptake of interventions when they have to run an intervention, what motivates them. And so we interviewed 20 people from the clinics themselves who were clinic managers or implementation staff, largely providers, as well as a few interviews with district health managers. And what came from that was a couple of factors that they identified, and I'll walk through these. Clear perceived benefit, availability of adequate resources, and clear lines of authority and communication. So when you talked to the providers about the benefits of potential interventions that they could be implementing, potential changes, they repeatedly focused on what the patients were likely to think about it. And it's important to note here, you are talking about providers' perspectives of their patients, which may or may not always align 100% with what the patients are actually thinking, but this is what's going to drive a provider's behavior. But they were really very, very attentive to whether or not they thought this was going to work for their patients. And they framed this often in terms of convenience and time savings to the patients. They noted programs where there was a problem because they felt that their patients needed more privacy, and the programs that they had been asked to implement didn't provide it. They raised the issue of stigma and highlighted examples such as you can see in the quote on the right there, where a program really potentially exposed a person to stigma, and so there was concerns about it. And they also really highlighted interventions that addressed pervasive problems like overcrowding. In terms of resources, this is not a totally unsurprising area to have a focus, but they really pointed to space and staffing shortages as being key barriers for a lot of what they had to do. And noted that there were challenges with some positions being frozen, basically not filled while vacant. And because in the South African healthcare system, you have almost all of your care is being provided by women, there is a fair amount of maternity leave that just comes up. And so you end up with a lot of positions that also sort of have a kind of chronic percentage of people who will be out when you just, work through who's likely to be pregnant and when it's likely to happen. So these staffing shortfalls, along with the space crunch, were really salient. And then importantly, they really pointed to places where the system needed better alignment, so that there were interventions where, there hadn't been communication, or there would be a communication breakdown between, say, the providers and the patients, or particularly between clinic staff and local non-governmental organizations. And there's an example there in the box on the right where, the organization had been funded to try to get people into care, and they wanted the providers to set up an appointment system, but the reality of the patients' lives was such that the appointment system was never going to work. And so the NGO had been funded to do one thing, and the providers were like, but we can't help you with what you've been funded to do. So the system had had a mismatch in the way that this had been set up and aligned. So what does this tell us? Well, the provider perspectives are driven by patients as well as by their own needs. So there's a buy-in thing. That's not particularly surprising. You also got a buy-in, but there's this keen awareness of resource adequacy when evaluating an intervention, and it really drives what you're seeing there. And then an intervention needs to foster good alignment among other system components. And you have to keep in mind that that an intervention may work in one part of the system, but it will have indirect effects for other parts. So I'm going to stop there on some South Africa work. I'm going to jump now to talking about some work that was done here in the United States. This particular work was funded by the HRSA and its HIV/AIDS division through its special projects of national significance. I'm just going to note this is a very particular funding mechanism that comes with certain kinds of strengths and certain kinds of realities that you have to deal with. Its strengths are that HRSA basically funds an evaluation center and technical assistance provider to lead a large initiative. And then you have all these separately funded demonstration projects that you get to work with. So you get a scope that is much larger than you might see in something like a standard NIH R01, which in the context of studying something like a system is very helpful. The challenge that comes with it is that you're not allowed, you don't get to run this like a randomized control trial. So you don't get your kind of standard control condition in the same way. And so you have to use statistical modeling, and you have to use qualitative research and other kind of mixed method strategies to understand what's working and why it's working, and to derive your lessons learned from it. But in the context of this particular project, and this is differently oriented than the work I was just talking about in South Africa, here what happened was HRSA basically solicited from a variety from sites proposals to transform their practice to to address the potential for workforce shortages. And so the idea here was, could you construct a more efficient form of care but continue to keep your HIV outcomes high, if not improve upon them? And so what you ended up with among the 15 sites that were funded were really three kinds of transformations that people were talking about. What here is called maximize the workforce, which is what the journal ended up preferring. We use this as a term. You could really think of this as training new providers to, basically moving HIV care more towards primary care and away from HIV specialists. There's a share the care or task shifting where you're moving the certain things that were on historically the provider's plate, moving them off the provider's plate towards clinical staff. And then also an enhancing client engagement. So trying to keep people more reliably in primary care so that the very high demand need for urgent and emergency care was reduced. Before launching this, we asked sites to actually engage in a pre-implementation preparation process. And there's a set of things here that we asked sites to do. And, one reaction to this list I will acknowledge is you might say it seems kind of obvious. My rejoinder to that would be you'd be surprised. We had actually a lot of pushback from sites about wanting them to focus on this. So it's not always something that people intuitively do, even when the system is ready to make a change. The other thing is that the list here is not theoretical. It's derived from experience. So for example, we did work years ago, colleagues and I, looking at the rollout of electronic health information exchanges. One of the things that came from that was the critical importance of getting your policies and your procedures simply written down. The absence of that left things a little bit all over the place. You're assessing your data needs and infrastructure. From that same study, it was clear that simply having data available is not the same thing as actually being able to use and access the data. And so having protocols and things like that in place that let you get to the information you're going to need to be able to drive the change and to monitor the patients in the way you want is critical. So the sites were asked to engage in this process before they launched. And we, of course, looked at how that went for sites and what worked and what didn't work. And the kinds of things that you saw as more successful are some of those that are listed here. So there was a strong emphasis on visioning exercises to refine goals and objectives. And this may sound very corporate America or something like that, but the reality is that even when you take an intervention like we're gonna shift care over to primary care providers, what each stakeholder understands that to be and what they think that's going to look like and how they think that should roll out is not always the same. And so making sure that your leadership, your providers, your patient stakeholders, that everybody actually is in alignment on those things is critically important in order to nail down what that intervention is going to be in your site and the way you're going to put that together. One of the ways that proved and has consistently proven in studies that I've been on useful for this is a whole process mapping exercise. I'm coming from some of your quality improvement literature, but basically pulling people into a room and saying, how do we deliver this facet of care and what does it look like currently and how will it be changed? Is a great way of getting people to understand concretely what the model is that you would be planning to roll out with the change you're making. It's also particularly good, though, for addressing these things like in the prior study was talking about concerns about resources. This is where you can get at it because this is where staff are able to air their concerns about, are we going to have too much demand? Are we going to be able to handle this? If I'm being asked to do a new task, what's being rolled off my plate? And so this is where you can help address those concerns about resource adequacy and equitable distribution of the labor. The team huddles and other sorts of strategies for regular communication among team members is obviously always important, but particularly so when your change is introducing new players into the mix, such as in the share the care model, or for example, in the South Africa work where you you suddenly have peers in the picture who are offering care. And then this iterative implementation rollout, right? Unlike your kind of classic research study, where you might be thinking of things in terms of, no change, and then tomorrow I flipped on the change. It doesn't work that way in a system. It's gonna come out in fits and starts, and so you've got to allow for that iteration. These lessons were all compiled into 3 tools at HRSA's preference. The tools were placed on their website, so these are not things that went into journals, but rather were prepared as implementation tools that grantees from HRSA could use and are available on HRSA's Target HIV website. We also, though, then evaluated what the findings were from these changes, and so we did this using 2 major components of the research. First, we conducted an organizational assessment every 6 months, where we measured what was going on in the clinics and what the delivery of care looked like. And we anchored this to something called the building blocks of primary care assessment, which included an HIV-specific addendum that we created. And in that addendum, we basically built out questions that looked at the kinds of changes you would need to make to expand or maximize your provision of care, to shift towards more task sharing and sharing of the care, as well as to improving patient engagement through population management and coordination of care. And for each block, you had a set of items that were answered by the site at each round, and then those were averaged to create a score. And then we looked at the change in the score. And as just an example, here is one of the items from the one looking at basically shifting your care towards a more of a delivery within a primary care setting. And what you can see is that you basically, you continue moving up towards offering more advanced forms of care. And there was other questions that then captured to what degree that was embedded within a primary care setting, as opposed to being relegated off to a specialist. We also, the second component was we were able to get client level data from HRSA. So all HRSA funded HIV-related sites file these Ryan White services reports on an annual basis. And we were actually able to get HRSA to provide us with the RSR data for the clinical sites taking part in this initiative, which is not something that's typically happened. There are about 13 to 15,000 clients being served per year. Varied a little bit from year to year, but demographics and everything else suggested you weren't seeing big shifts in the types of clients being served. And we got this by having each of the sites give us these unique anonymous HRSA identifiers, which we then gave to HRSA, and they pulled the data for us. And we looked specifically at prescription of ART retention as it's defined by HRSA, which involves having 2 appointments over the course of a year spaced 90 days apart, as well as viral suppression. And what you see is that over time, there was a gradual uptake in all of the different, for all 3 of the practice transformation models. There was an uptake in practices consistent with those models being implemented. This is a little bit busy of a slide, but I pulled up the maximize the workforce as a larger image just to make it easier to see. The trends are really quite similar across the 3. I mean, overall, you're dealing with Ryan White program settings, which usually have very good outcomes to begin with. But what you did see was increases in retention, prescription, and viral suppression as you moved across the years and as these interventions, even after rollout of these interventions. And I will note that there is a question has been asked by no less than the director of the HRSA HIV/AIDS division about to what degree is some of this just due to temporal trends. And undoubtedly, there is some temporal trend that plays into this. This is a limitation of not having a control group, but it's worth remembering this was a study in which we've rolled patients into getting care from providers who had not done HIV before. We rolled people into getting care from more from staff than from providers. And so we were really looking at not seeing outcomes drop. And so the fact that you achieve outcomes that are similar to or exceed kind of the national trends is favorable given the nature of the study. We also did do some qualitative work as part of this, and I just want to feature one particular analysis we did where we looked at 2 of the demonstration project sites that actually forcibly asked patients to adopt a primary care provider separate from an HIV provider. And there was a lot of concerns about how popular this would be or unpopular it would be. And what we found was that patients actually appreciated the reasons for the change and ended up wanting to see their PCPs because it let them get certain needs met that weren't being well addressed by an HIV provider, and to take care of conveniently located services where their PCP was. I will note though that one of the sites actually shifted how this was going to work so that the PCP ended up in the same location as the HIV specialist because of patient concerns about changing their location. So what do we take from this in terms of systems change? Well, one should not assume that an intervention can simply be picked up and just rolled out, right? There is a whole process here with a particular amount of time and energy needed to align your vision, as well as working through people's concerns about resources and capacities, and recognizing that you can also move the system and include moving patients in terms of the changes when it's clear that there are benefits. And of course, you're going to need time and iteration consistent with the time and energy thing. So let me just say quickly here, because I know we're coming up on time in just a few minutes here. Let me just say a little bit about some work that's been done during the COVID pandemic. So going back to South Africa, following from some of the work I presented earlier, in light of the fact that we had this intervention that hadn't successfully scaled to be taken up by the district, we got money through an NIMH R21 to develop a culturally appropriate measures for organizational readiness for change. And the way we rolled this out is we convened an expert panel of providers and academics and people who worked in the system and everything else to talk with us about what we would need to get at for organizational readiness. And they really focused on 2 things: a kind of locus of commitment. What are your motivations for actually making a change? And then, consistent with what we'd heard in other studies, is resources for change. So we assessed whether or not we developed a measure that assessed whether or not a person personally felt like they had the resources to implement a change and whether their clinic did. Once we had drafted items, we did cognitive interviews with 25 providers to run through the items and to get their perspectives. And really the primary thing that came from this was a lot of discomfort with some of the locus for change items that we had. We initially had more than 4 items, and providers basically did not want to answer any question that implied that they might be engaging in a change simply because they had to. They always wanted it to be because they wanted to do it. They were much more comfortable, though, with the resources for change measure. And then what we did is we looked at how their perspectives on this aligned with their perspectives on 2 different changes: new ART guidelines and clinic decongestion. The measures when applied for both kinds of conditions were reliable. In general, they worked better with the clinic decongestion than it did with ART guidelines. And there's some part of that may be a COVID story, which is that COVID really disrupted the rollout of new clinical guidelines for ART, dolutegravir, and just anecdotally, we'd heard about a lot of problems of it. And so it makes the measurements there a little funny, I think. But the other thing just to note is that is that it's this last bullet point on this slide here. The measures showed very good individual level reliability, but one of the things we did not observe that we had expected to observe was we didn't see much clustering of responses within clinics. And that seems to be due to the fact that there had been frequent staff changes and job reassignments due to the pandemic. And it really meant you lost a kind of clinic culture to some degree in terms of what people didn't have that in the same way, which when you're trying to study organizational readiness is complicating. And then let me just quickly note, using just this slide and another, just to say that meanwhile, domestically during the COVID pandemic, we had a capacity building initiative also funded by HRSA, where we were funded to work with 4 jurisdictions in the United States to try to develop a planning process that could then be used to roll out changes in your care system in the jurisdiction to address HIV-related disparities. Now, the original design of this was to have this serve as a process that would, identify a couple of interventions, follow them through, and you'd be able to track those changes. The study, though, started in the middle of 2019, and 6 months into it, what you had was a mass disruption in the care system due to COVID. And in 2 of the jurisdictions, that was then followed by disruptions thanks to climate change. So 2 of our places were in the south and affected by flooding and hurricanes. And so when what we've ended up with is kind of 4 jurisdictions that each you have to do a case study on them. And I'm not going to have time to go through the 4 case studies, but there are some lessons that cut across it that are important when thinking about change in a health system. And what you see is that major emergencies such as COVID tended to unify the goals and objectives. So right when COVID hit, everybody became focused on, because they had to be, how am I going to deliver care remotely? And you had no problem. Everybody's agenda was oriented there. And furthermore, because of the emergency, it creates opportunities for change, right? Like funding, rules around billing change to make remote care possible, to be able to do virtual care. But whether those changes actually proved sustainable has a lot to do with those other factors that I talked about in some of the other studies. So we had a bunch of sites in some of the jurisdictions that rolled out virtual care, but they really didn't go to the trouble of figuring out how that was going to work in their system particularly well. And they didn't like it. And the minute they were able to, they rolled away from it. And other sites did a much better job of kind of making virtual care work. And then they sustained it once it was done. Okay, let me just say, because I really do need to stop here, that we do have some other projects that are ongoing at this point. They're a little too early to have data, but there is a 9-state project where we are now trying to look at how you guide improvement of services for Medicaid beneficiaries with HIV. So this is taking some of these lessons learned from HRSA and rolling them into how to make changes within the Medicaid system, which has kind of very different incentive structures. And I am involved, I am one of the MPIs for a project on enhancing HIV care engagement in India, where we have taken the navigation model from South Africa and now paired it with a model that had already been developed, an adherence intervention and improvement model in India, and we put it together and added the navigation component to better address the needs of gay men and trans women who, because of stigma, they've had more trouble engaging in the sort of traditional interventions. So I will just say, as I wrap up here, I think as we go forward in thinking about health systems, that we really are going to have to think, I think the big area we're going to have to look at is workforce shortages and disruptions from things like climate change events. We are seeing a system that is increasingly taxed. And so when you think about making changes, it's how to make those changes effectively in a system that is facing that kind of taxed condition. And I will just close now by saying, as I've run through these studies at kind of breakneck speed, what are those factors that would drive and affect change? Well, here's the things that come from it. If I had to make a list of priorities, the first is to understand your system context. Not all, just like people, not all systems are ready to make a change at all moments in time. Related to that, you have to have a key focus on alignment of goals, recognizing that not all stakeholders are similarly situated or have the same objectives themselves, and you have competing demands, and kind of one intervention can affect another. And keeping in mind that in particular, providers are likely to be attentive to the preferences and values of their patients. You do have to think about adequacy of resources. Our eye care intervention that I started with, one of the major reasons it didn't translate outside of the study was that money moved away and providers really just didn't have the capacity or bandwidth to supervise the PN. So that was the driver there. And then documenting protocols, which again may sound obvious, but isn't something people really like to do, but is incredibly important for getting down that common vision. And it's also a way of making sure that you have aligned your intervention with other interventions that may be ongoing. And then finally, keeping in mind iteration and the fact that not everything is going to roll out. You can't do it all at once in a system. Okay. So I just want to thank, I probably forgot a collaborator in here, and if so, I will apologize for that profusely. And thank you, and now turn it over for questions.
Hi, Wayne. I actually have a question.
Sherry.
I don't know if people have their hands up. I see some claps, but one of the things that came up in some of our conversations recently is just like how one defines a health system. I think usually when we use the word system, people think of things like Kaiser, UCSF health system. But I think, health systems can also be sort of other delivery mechanisms. And I wonder if you might want to, expand on, just the term. And when we talk about getting involved in health systems research, like what it could encompass.
Yeah, I mean, it's, I think this becomes, it's easiest to see this when you talk about doing something like working with a jurisdiction. So I was not in a research context, but just involved with the San Francisco Getting to Zero initiative to prevent and improve upon HIV outcomes here. And, you're not just looking at something like HIV care. Those kinds of getting to zero initiatives encompass things like, for example, the kind of food support services, right? The housing support services, things that really address those social determinants of health. And it's getting that system. I mean, a lot of the research here didn't really get into this specifically, but it's getting those parts, things that are part of systems that traditionally were separate, now trying to make them one system and getting them to talk to one another. And so that's really where you've got to, I think, expand out the vision for what we mean by a health system.
Unmute. Yeah. Thank you very much, Wayne. That's a great talk and obviously very broad. So I'm going to do a broad question. So forgive me. But when we're talking about systems, I think we're also something which is sometimes forgotten is that our intervention as an academic intervention with NIH funding or HRSA funding is kind of part of that system. And I think you also mentioned how do we, you mentioned the funding disappears and then the intervention disappears as well. From that kind of broad experience that you have, do you have any ideas about how we can, let's say, build into the intervention the long-term funding rather than let's see if the resources are available in the recipient organization, because that seems to be often we're kind of waiting to see whether they can take it up, as it were, the personnel can take it. Yeah.
It's a great question. And I will say it's easier said than done depending on the intervention. I mean, so people who are say rolling out, this isn't very common with our division, but if you're rolling out something like a new medication, often the kind of pathway by which that new drug regimen would get funded outside is pretty straightforward. It's going to get covered by insurance and or programs like Medicaid or something like that, and off you go. Some of the stuff that we do in this division, these kind of support, more behavioral or complementary supportive kinds of interventions, really variable. And so I will tell you, within that practice transformation initiative, there was one site that built up a whole model for community health workers to be funded through its local Ryan White program. And then the Ryan White, the local planning council and the local Ryan White program put out different standards for what they said you had to do to fund a position like that. And so the whole model that they had built up, they had to unwind and then rebuild up to meet the new standards. And so I would say, as you're going forward, I think one, you have to ask yourself the question, how would this be funded outside of a research study? And then from there, think about, can you make that work with the system itself? And so it does require that you look towards, like, in Medicaid, what are the policies within Medicaid? What kind of positions can you fund? With Medi-Cal, there's a whole question about, would you even be able to survive on the reimbursement structure you're going to get from it? Or, are there opportunities that may not be research funding and maybe time delimited, but that you can make use of? So we've had the ending the HIV epidemic here in this country, and a lot of the sites we've worked with on a lot of different projects have really gone and made great use of that. It has provided this kind of flexible sort of funding that lets you address things that are not typically addressed by medical care. And then, of course, there is a kind of advocacy, if you will. You're not supposed to do that with federal funds, but there's a kind of advocacy for changing the system or changing what something like Medicaid or what an insurance company would pay for. And Susan, I see your question. To what extent do various organizations want to make the change? That's a great question. So in the context of something like a SPINS initiative, usually the answer is they do, because they come to it proposing something. In the context of an intervention that we start with and we want to roll out, say more like something like eye care, there is more of a sales pitch that has to go into it. And I will note that when thinking about the perspectives of patients, I will just say that my general sense, both from some of the work I presented, but from some other work, is that providers have a keen understanding of their patients, and they are especially good at sniffing out the difference between something that patients really want to do versus something that was acceptable, right? So we do a lot of acceptability studies and things like that. That doesn't mean it necessarily translates into something that really sings to the heart of the patients or the providers. And so, the more you can make it something that they see that personal benefit to themselves, and that personal benefit may not, in the case of a patient, it's going to be, you're still getting the care and the support you want. In the case of the provider, it may or may not translate into something like less work, but what it does need to translate into is, I have the capacity to do the work I'm assigned to do. The big thing they're going to be concerned about is that you have exceeded capacity to meet expectations. And then, of course, you're left in this thankless position of being worried that you aren't going to succeed, and you're going to get in trouble for basically not meeting your goals and objectives. And every new intervention that rolls out typically adds something to the panoply of services that are there, and often adds to the kind of expectations. It's less often that it actually subtracts in a clear way.
Thank you.
Do we have time for one more question?
Can I ask a question?
Hello there.
Dr. Stewart, I'm a nephrologist. I'm coming from this with the lens of how we are trying to figure out exactly what you said in terms of workforce shortage to deal with all the patients with chronic kidney disease. And in our field, there has been, I would say, the past 5 years, a growth of private entities, I would say, or industry interested in doing sort of risk sharing with health systems to manage their panel of patients with chronic kidney disease in the primary care setting. And I was wondering if there are examples of that in the context of HIV and how successful they have been.
You know, it's a good question. I don't, so there's a couple of layers to this answer. So certainly in the context of the way that we have historically done insurance in this country, you can build these kinds of examples because your HMO model is actually technically a private company, an insurance company that buys the risk for a patient and then is assigned the responsibility of meeting their care needs, and they profit on whether or not they do that effectively, or, you know, less generously, whether they cut corners on the patient's care, right? But I will say that what is clear, so that definitely exists in HIV. I mean, you know, Medi-Cal, for example, uses it in this state. We heavily require patients to be rolled into these kinds of private care entities like this, or insurance entities. Now, is there like a private, I don't know, Google or something is trying to do that, Amazon or some company like that? Not as familiar, but what I can tell you is that when you look at the insurance models for this, that kind of funding often provides a flexibility that you can't get with the fee-for-service kind of model in the more traditional way we do care. So that it's so the navigation style thing is far more easily funded when you're buying the risk and you're owning it, and then you're trying to do whatever it takes to keep the person healthy. So there's a lot of ways in which that can really work. Where there's less, so Emily Arnold and I have for years led a policy research center here, and what we've seen in California, where you rolled people out of Ryan White during Medicaid expansion and into some of these private companies, was that, you know, they didn't have the kind of expertise and the diversity of experience to serve the kinds of patients they needed, or in some cases, really, there were certain things carved out of their contracts and it bifurcated care. And so that's where the kind of negatives come with that model.
All right, I think we have gotten to the end of today's town hall. Am I correct? Thank you everyone for joining us. Thank you, Wayne. Thank you, Rochelle.
Thank
See you
you.
next time.
Bye, everyone.